This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2018. All rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Ventilator Discontinuation, the evidence base, guidelines, and best practice. Dr. Neil MacIntyre is a professor, medical director at Duke University, and fellow of the AARC. Dr. MacIntyre discloses relationships with Ventec, Breathe, Inspirex, and Alana.
Welcome to our discussion of the ventilator discontinuation process. I'm going to go through some of the evidence base, some of the guidelines, including guideline updates, and what I consider best practices. So to begin, I think it's important that we realize that there are two basic reasons patients remain stuck, if you will, on ventilators. Number one is they're too sick, and that's depicted on this little balance cartoon here I've got. On the right, we have the capabilities of the patient, the neuromuscular drive, muscle capabilities, and on the left, we've got the demands on the system, the ventilation loads, the compliance loads, the resistance loads, and imposed loads that we sometimes put on patients unintentionally. And when this balance is way to the right, we have normal neuromuscular capabilities, the demands are low, we obviously do not need a ventilator. And patients who are too sick usually have excessive demands on the system, and the neuromuscular apparatus is weak, and the balance shifts way to the left. What we're going to be discussing here today is recognizing when this balance starts to tip to the right and how to manage the patient during that process. So, reason number one that patients are stuck on ventilators is, again, they're just too sick. But there's this very important second reason patients are stuck on ventilators, and it's us. It's us. Ventilator dependency can be iatrogenic. This was first, I think, illustrated very nicely almost 20 years ago now by two large trials conducted in Western Europe, Esteban and Brochard. And they were actually interested in trying to decide if a pressure support weaning strategy or a gradual increasing TP strategy or an SIMV strategy was the best way to manage patients coming off the ventilator. And so what they did is both of them did very large trials comparing these various techniques. And one of the most interesting parts of both of the trials is that to get into the trial, the patient had to prove to the investigators that they were indeed ventilator dependent. So what'd they do? They went around to these ICUs and they asked the clinicians there, show me your patients who you can't get off the ventilator. Just show them to us and we'll see if we can enroll them in our trial. So they did that. And interestingly, they subjected all of these patients to a spontaneous breathing trial. And you know what? Almost 3/4 of the patients passed a spontaneous breathing trial. They did not need the ventilator. The clinicians did not recognize that they could come off the ventilator. So even though these trials are touted as comparing weaning strategies, I think one of the most important messages is that we have to be very vigilant in making sure our patients are being checked on a regular basis for the ability to come off the ventilator, because we can often miss it. Another way of looking at this iatrogenic problem is unplanned extubations. And this is a large collection of patients I borrowed from Scott Epstein. And what I want you to look at here is that you will notice that the majority of patients who accidentally extubate themselves, or maybe intentionally extubate themselves, they're actually right. They're correct. They can thrive off the ventilator. So again, very important that we are vigilant in making sure that our patients are being regularly assessed for their ability to come off the ventilator, because often we can miss it if we are not careful. So Failure to recognize discontinuation potential is a major cause of iatrogenic ventilator dependency. But there are other factors as well. Imposed loading. We don't set the ventilator properly and we don't give them enough support. We have triggers that don't respond properly. We have flow dyssynchrony. We don't match the flow to the patient's demand. We have cycle dyssynchrony. All of these things can contribute to muscle loading, what I call imposed loading, and can make the patient more difficult to come off the machine. Another thing is what I call weaning rules. And these are protocols that that clinicians put into play to try to manage these patients as they come off the ventilator. And we have to be really, really careful that the rules don't put unappreciated or under-recognized obstacles in the way. We can force a delay in ventilator withdrawal and discontinuation if our rules are not written properly. So for instance, let's say you have a protocol that says let's do spontaneous breathing trials every 3 days. Well, you can see right off the bat you're going to have a problem there because that's going to delay the process. And finally, unnecessary sedation. When patients are a little uncomfortable or anxious, there's a tendency to not address what's causing the anxiety or the discomfort. Instead, just ratchet up the propofol or ratchet up the fentanyl. A bunch of reasons why ventilator dependency may be iatrogenic. Very important series of studies and guidelines came out back just around the turn of the 21st century. And I want to highlight a couple of them. Number one is a very, very large literature review done by McMaster University up in Hamilton, Ontario, Canada. At about the same time, a series of guidelines were put forth by the American College of Chest Physicians, the Society for Critical Care Medicine, and the AARC. And these were published in 2001, and I've been asked to review these from time to time, and I must say most of these guidelines really apply today. In 2017, the ATS, the ACCP, and the European Respiratory Society got together and looked at these guidelines and added some updates. But as you'll see, as we go through these, you'll find that these updates don't really substantively change what was published back in 2001. Let's look at what was done back in 2000-2001. This group got together, started in May 1999, and they took this McMaster report. And this McMaster report was huge. It reviewed over 5,000 papers, and it came up with a number of parameters that were useful, and the guidelines committee took this information and created, as I said, 12 important evidence-based guidelines that were published in Chest and also the summary in Respiratory Care in December 2001, January 2002. What did these guidelines, what were they built on, and what do they specifically say? So this is the McMaster review, and they found 88 parameters that had been studied looking for predictors to guide the discontinuation process. And after reviewing this literature very carefully, they found 8 that were really quite helpful, And they're listed on this slide. There's the minute ventilation, there's the negative inspiratory force, the maximum inspiratory pressure, which is very similar, the P.1, which is the pressure a patient can exert against a closed shutter after 100 milliseconds of occlusion, and then an integrated index that included mechanics and gas exchange called the CROP index. There were also 3 parameters. Let me go back a step. Those 5 could all be measured while the patient was on the ventilator. And then there were 3 others that were found to be useful during a brief, couple of minute, spontaneous breathing trial. It's the respiratory rate, the tidal volume, and the respiratory rate divided by the tidal volume, the so-called F to VT ratio. Some people call it the rapid shallow breathing index. All 8 of these parameters really correlated nicely with success in getting a patient off the ventilator. The problem was each of these in isolation were not strong enough to really guide decision making. They correlated very well, but in terms of actually guiding decision making, each one in isolation really wasn't strong enough to be recommended as the number to follow for ventilator discontinuation. Trying to figure these predictors out is a challenge. Most of these studies that were reviewed by McMaster and studies since done, it's kind of interesting because they study a predictor in a group of patients that the clinicians feel might be ready. And that's okay, but it's only useful in confirming a clinical suspicion. It cannot evaluate the role of that predictor if the clinician doesn't think the patient's ready. They won't get enrolled in the study, they won't be studied. So right off the bat, you can see there's a problem with many of these studies looking at predictors because they're not predicting everybody. They're only predicting those that the clinician feels are possible. So as a consequence, as each new predictor is studied and reported, it only can stop the discontinuation process. In other words, it only works in patients in whom the clinicians think they can go forward. And again, we don't have the ability to use those predictors in patients that clinicians are not comfortable with. Clinicians won't enter those patients into the study. At the end of the day, as I say, no single predictor is useful as a tool to guide the discontinuation process. Instead, what the Guidelines Committee said is you need to do what they called an integrated assessment using several parameters, and I'll cover those in just a moment. These are the data illustrating my point. The spontaneous breathing trial with an integrated assessment is the fastest way to come off a ventilator. These are data from those two trials I mentioned a little while ago, the Esteban and the Brochard trial. And these are a number of different ways of following a patient and guiding a patient through the discontinuation process. And you can see probability of remaining on the ventilator on the vertical axis, time on the horizontal axis. And I'm not going to belabor this slide, but what I want to illustrate is the curve on the far left that gets patients off the ventilators quickest has nothing to do with adjusting the ventilator. Nothing. It's simply doing a spontaneous breathing trial with an integrated assessment on a regular basis. And if the patient fails, as I'll talk about in a minute, you just put them back on the ventilator and try again at a later time. With that in mind, the Guidelines Committee said every day patients ought to be screened. Some people call this the wean screen. Ought to be screened for the potential to have a spontaneous breathing trial. And there are four parameters that are easy to assess. I hate to say it, you don't even have to go in the patient's room to assess these. First, are they stable? Are they stable? If the infiltrates are getting worse, well, this is not a day to talk about discontinuation. So it has to be stable and preferably getting better. Number two, they have to have decent gas exchange. You can pick whatever parameters you want. P to F ratios above, say, 200, P less than 5, maybe 8, FiO2 down in the 40% range, pH above 7.25. These are suggestions. They're not cast in stone, and you should use what you're comfortable with as being stable, acceptable gas exchange support. Number three, hemodynamic stability. And an easy way to assess this is, do they need inotropes or chronotropes? If they do not, well, then they pass step 3. And finally, will they breathe? Are they too heavily sedated or even paralyzed to undergo a spontaneous breathing trial? So those are your 4 questions. If you pass all 4 of those questions, then you go to the SBT, the spontaneous breathing trial. And it is the most effective way of assessing discontinuation potential, as I showed you a moment ago. So how do you do this? The original guidelines said, take your choice. 5 centimeters of pressure support, 5 centimeters of CPAP, automatic tube compensation features, or just a T-piece, a T-bar. I would point out that the T-piece or the T-bar is probably the closest to mimicking what you're going to see when the patient is extubated. There's going to be post-extubation edema in the glottis and the larynx, and so if you just do a T-piece with the tube in place, it most closely mimics those conditions. But nevertheless, the Guidelines Committee said pressure support, CPAP, etc. were all equally effective. Now here's the important point. It's an integrated assessment. It's not a single number. Number 1, the ventilatory pattern. And most importantly, does it change? There are patients out there with very stiff lungs, interstitial fibrosis, who are going to be tachypneic. So a hard and fast number is not really useful. It's looking for a change. Gas exchange, do they stay stable? Do they stay stable? Does their pulse oximeter stay in an acceptable range? Hemodynamics, do they get tachycardic, bradycardic, hypotensive, hypertensive? And finally, hard to define this, but every good respiratory therapist knows what I'm talking about. How do they look? How do they look? Comfortable. Now you notice I didn't give you any numbers to base this on. In fact, a lot of people talk about the rapid shallow breathing index that I mentioned before. They use the number 105 as a cutoff to determine if they should proceed with discontinuation. I think, again, that number, a single number, is a useful correlate with success, but I would not use it as a determining cutoff value. Scott Epstein did a wonderful study, or his team did, where he had patients being discontinued using a hard and fast 105 RSBI as a cutoff versus the integrated assessment I'm described on this slide here. And what's important, he found that having a rigid cutoff actually slowed the process down. So again, when you're doing these spontaneous breathing trials, I really caution against an arbitrary cut point. Instead, you integrate these assessments that I've described to you here into a decision that the patient either did or did not pass the spontaneous breathing trial. Now, the Guidelines Committee back in 2001 said this trial should last probably 30 minutes, but no more than 120, 2 hours. If you haven't decided if the patient is ready to come off the ventilator by the 120-minute mark, they're not ready. They're not ready. Okay, so that's the spontaneous breathing trial. And as I say, it is the most effective way of doing it. I'm going to come back to the update here in a little bit, but one of the updates in 2017 is that 5 centimeters of water pressure support is now the preferred strategy. I'm going to go on record as saying I'm not sure I would have agreed with that. I still think the other approaches are equally valid depending upon the clinical situation. But that is the number one recommendation of the updates that were published in 2017. Okay, let's assume the patient passes this spontaneous breathing trial. They're looking good. Now what do? The next decision is whether you're going to take the tube out. And that's a different set of assessments than deciding whether or not the patient needs a ventilator. So taking the tube out is a different set of assessments. Cough is absolutely critical. Patient has to be able to cough. Some people have argued you could measure cough velocity. Just look at the expiratory flow signal on your ventilator during a cough. And various cutoffs have been proposed, 1 liter per second, some say 2 liters per second. But it is an objective tool to assess somebody's ability to cough. The white card test, I'm afraid I haven't used it, but I think the visual is very useful. So what's the white card test? You get one of those little 3x5 index cards, and you disconnect the patient from the ventilator, and you put it in front of the endotracheal tube, and you say to the patient, cough. And if the secretions, the goobers, hit the white card, that's considered a positive test, and this patient can safely protect his or her airway. Like I said, I've never done it, but the visual, I think, is very instructive. What a lot of people use is suctioning frequency as an index as to how well the patient can protect the airway. And a general rule of thumb that was endorsed by the Guidelines Committee back in 2001 was that if suctioning is required more than every 2 hours, that patient is probably unlikely to be able to protect their airway. Less important, you don't need a gag reflex. Gagging has nothing to do with protecting your airway. A cuff leak, very controversial. A big airway with a little bitty tube will always pass the cuff leak. A big tube and a little bitty airway may never pass the cuff leak. So unless there's a clinical correlation, known airway disease, upper airway problems, I don't find the cuff leak to be a very useful parameter to follow. And finally, what often holds people up is alertness. There are a lot of clinicians who want to see the patient literally doing the New York Times crossword puzzle before they'll take the tube out. And that's not necessary. You do not have to be wide awake. A Glasgow Coma scale of 8 which only requires some responsiveness on the part of the patient, is all that really is needed. All that's really needed to assure that the patient will have good airway protection. So don't be dismayed if the patient is not wide awake conversing with you in terms of deciding whether or not to take the tube out. So a correlate to this is sedation. You don't want the patient heavily sedated. You want them to be as alert as possible. You want them to be able to cough. But that doesn't mean you have to have all sedation off. I have extubated many a patient on a little bit of Precedex or a little bit of propofol just to tide them over during the extubation process. As long as they're awake, as long as they can respond, and as long as they pass my cough assessments. You can expect extubation failures, and I'll come back to that in just a moment, because I think extubation failures are kind of an interesting guide to your own philosophies. So going back to the CNS effects, this is a very busy slide. I don't expect you to remember it, and it may be difficult to see on the program here. But I've highlighted the point that you don't need anything more than a GCS, Glasgow Coma Scale of 8, to safely extubate somebody. And again, these data also emphasize the importance for the ability to protect your airway and the ability to cough. As I say, extubation failures is an interesting parameter to follow, a quality indicator in your ICU. The notion is if your extubation rate is really low, your reintubation rate is really low, only, say 2 or 3% of your patients get reintubated, there are data out there that suggest this is too conservative. You're missing potentially extubatable patients. And of course, the flip side is true as well. If you're reintubating 50% of your patients, next time you want to take a tube out, you might want to take a time out. That's way too aggressive. Again, this is Scott Epstein's data that's looked at a number of different ICUs around North America. And as you can see, sort of the national average, and I think a reasonable rule of thumb, is that about 12.5% of your extubations ought to be requiring a reintubation. You guessed wrong. So again, you don't want to be too conservative, you don't want to be too liberal. And a quality indicator of right around 10, maybe 12, 15%, I think is a useful parameter, and it's a parameter we follow back home to monitor our practices. Okay, if you do this on a routine basis, you actually improve outcomes. This is one of the first of these studies. This is Wes Ely's study from the New England Journal 20 years ago, or more than 20 years ago, where he showed that if you do a protocol that requires daily spontaneous breathing trials, and you do it with a RT-directed protocol, look at that. You shorten ventilator days, you shorten weaning days, you shorten ICU days, you even reduce reintubations, which I found interesting. And of course, costs go down. So this is a strategy that works, and it has been adopted by many hospitals around the globe, daily spontaneous breathing trials. So we've talked about the patient who passed the spontaneous breathing trial. What about the patient who fails? What about the patient who fails? What do you do with them? First thing you do is kind of obvious. Why did they fail? Why did they fail? And you want to address all the reversible aspects of ventilator dependence. So things like loads, improving mechanics, metabolic demands, improving capabilities, nutrients, electrolytes, adequate oxygen delivery, adrenal function. This is an interesting idea, this adrenal function. These patients who have terrible systemic inflammatory responses often have adrenal insufficiency. And finally, sedation strategies. Again, I am a strong believer in sedation protocols. I'm a strong believer in reducing sedation as much as you possibly can, but I'm not an advocate of a very rigid spontaneous awakening trial. I don't think you have to have the patient wide awake off all sedatives to assess their spontaneous breathing trial and the potential to be extubated. Protocols, yes, but I'm not sure the SAT is absolutely required. And another issue that doesn't come up a lot is making sure their cardiac function is optimized. Sometimes pulling mean airway pressure off the patient can precipitate heart failure in somebody with a bad heart. Another reason to fail a spontaneous breathing trial. For patients who failed the spontaneous breathing trial, search for reversible causes. Second step, always repeat the spontaneous breathing trial 24 hours later. Now, I realize there are exceptions to this, and I'll come back to those in a little bit. In the rapidly awakening patient, like a post-anesthesia, you may want to do this trial more frequently. And in the long-term ventilator-dependent patient out there at 40, 60 days, you may want to wait for some additional recovery before you come back and do daily spontaneous breathing trials. But for most patients that I deal with, and I suspect many of you deal with in the ICUs, doing it every day, providing they pass the wean screen, makes all kinds of sense to me. Now, what do you do with the ventilator? What do you do with the ventilator? Well, there's a great urge to try to maybe reduce support, wean support. But you know something? Nobody has ever shown that gradually reducing support in between daily spontaneous breathing trials does anything other than waste your time and irritate the patient. So I am a strong believer in not manipulating the ventilator in between spontaneous breathing trials. Leave it alone, keep the patient comfortable. In between daily spontaneous breathing trials, put a mode of ventilation on that is comfortable, gives the patients a normal, if you will, type of workload. You don't want atrophy to occur by too much support. You don't want fatigue to occur by too little support. I like to use the pressure-targeted modes of ventilation because the flow synchrony is better. Patients will react and synchronize with the patient or with the machine better. But you also want to make sure you've got triggering set properly. This is particularly true in patients with obstructive lung disease who may have a lot of intrinsic PEEP. And you want to make sure that maybe a little bit of applied PEEP is being given to help with the triggering process. Again, variable flow with a pressure-targeted breath I think makes the most sense in keeping patients comfortable. And you want to be skilled at looking at the termination of the breath. You want to make sure the breath isn't too long. I want to make sure it's not too short. And you want to maintain this level without change, in my opinion, until the next day when you do another spontaneous breathing trial. So weaning the level of support in between spontaneous breathing trials, again, has never been shown to improve any outcomes. So again, triggering, sensitivity, applied PEEP, pressure, flow targets, variable flow. This usually requires somewhere in the neighborhood of 10, maybe 20 centimeters of water pressure. I usually apply somewhere in the 15 range. And again, make sure you're cycling the breaths properly. There are a couple of new approaches to improving synchrony. I don't have time to go through those. One is proportional assist ventilation, which applies pressure and flow depending upon what the patient's sensed effort is. And the other is neurally adjusted ventilatory assistance, very clever way of supplying respiratory support according to the diaphragmatic EMG. These both have theoretical appeal, both have been shown to work, but neither as yet have been shown to shorten the withdrawal process or reduce sedations. So I like them. They are expensive. They require some skill in setting up, but to date, outcome studies are lacking. So to sort of summarize, for patients who fail the spontaneous breathing trial, search for reversible causes, repeat spontaneous breathing trials every 24 hours, as long as they pass the wean screen, and in between, keep them comfortable. Keep them comfortable. And very importantly, I think protocols run by respiratory therapists are the way to go here. Respiratory therapists are the best out there in determining patient comfort, patient synchrony with the ventilator, and adjusting the ventilator accordingly. A word about non-invasive ventilation, as this has become quite popular in the literature. And there are two scenarios where non-invasive may be useful. Number one is the patient who's borderline spontaneous breathing trial. They just don't look quite right. You do it for 2 hours and you're just not comfortable. They're ready to come off the machine. They can protect their airway. That's important. They can protect their airway. And there's pretty good evidence, and it's getting bigger and bigger, that non-invasive ventilation in this population may be of benefit. This is particularly true of the COPD population. That's where the evidence is strongest. I find it kind of interesting because NIV, we use it on the front end of COPD to prevent an intubation, and now there's a lot of interest in using NIV on the back end to shorten the ride on the ventilator. So NIV in the COPD population who is kind of borderline SBT passing well, it has some good literature to support it. What about the other scenario, the failed extubation? You pull the tube and you were wrong. You pulled the tube and you were wrong. Now, if it's an airway issue, all bets are off. Non-invasive ventilation is not going to fix an airway issue. But if it's simply a muscle overload phenomenon, would NIV work there? Well, interestingly enough, in the COPD population, again, there's supportive evidence that this is not a bad idea. This is not a bad idea. If it's not COPD, there's more controversy. In fact, some would argue if it's not COPD and it's a failed extubation, you actually may do more harm than good in delaying reintubations with non-invasive ventilation techniques. So, where does NIV fit? I think it fits best with the COPD population, and it may facilitate getting patients off the ventilator quicker and extubated quicker, and may rescue some of those who fail the extubation, provided it is not an airway issue. So as I say, these guidelines were updated in 2017, and like I said, I was sort of both surprised and pleased that not a whole lot of changes came forth. The guidelines reiterated one more time that the spontaneous breathing trial with an integrated assessment, as I've described it, is the most effective way to assess discontinuation potential. As I mentioned before, these updated guidelines also brought forth the notion that maybe 5 centimeters of pressure support is the first choice for a spontaneous breathing trial. And while I have no objection to using pressure support, I'm going to go out on a limb here and once again repeat that I'm not convinced that you have to go to pressure support. I think the other approaches can also work depending upon clinical situation. Other changes. Non-invasive ventilation received a lot of interest in these updated guidelines and addressed the issues I just covered a few moments ago. So NIV is growing in popularity, and as I said, especially in the COPD arena. Sedation protocols were reinforced in these updated guidelines. Again, they did not mandate spontaneous awakening trials. Did not mandate spontaneous awakening trials, but did emphasize, as I tried to do a little while ago, did emphasize that protocols designed to reduce sedation as much as you can are going to be very helpful. A new guideline that came forth is one that has been discussed a lot in recent years, and that's getting patients mobile. Now, that doesn't necessarily mean getting them up and walking down the hall on their ventilator, but getting physical therapy in there, getting respiratory therapy in there. Move their muscles around, move their legs, sit them up, have them do some exercises on the bedside. These are being shown in a number of studies to be very helpful in facilitating the withdrawal process. And the cuff leak was addressed in these updated guidelines as well, but again, restricted only to those so-called high-risk patients, patients whom you know have an airway issue, patients who had to be reintubated a couple of times because of airway issues. Maybe that's a place where you might want to be careful with the cuff leak, and if you can't get a cuff leak, you might consider steroids helpful to reduce some of that inflammation. So those are the updates. Those are the updates. And as I said, I'm struck by the fact that most of the original 12 guidelines that I've been covering really didn't change a whole bunch. So how are things going out there in the real world? This is a nice study. It was in the Blue Journal. Just to show you that in the real world, in fact, over half of the patients come off the ventilator with their first spontaneous breathing trial. Over half. And maybe another 39% require a couple of spontaneous breathing trials. But you'll notice by doing the math on this, 94% of patients on ventilators actually come off with just a couple of spontaneous breathing trials. Having said that, I think most of you, like me, spend an awful lot of time worrying about those 6% who don't come off so fast. They are problematic, and they do require special, I think, management, as I'll touch on in a few moments. The long-term player. Fortunately, it's the minority, but as is often the case in clinical medicine, the minority of patients often consume the majority of our time. So a question that comes up with novel feedback regimens on our ventilators is, can we automate this process? Can we automate this process? First off, if you haven't gathered it by now, I'm a little suspicious that automated reductions in ventilatory support really has a role here. Because as I said, if you're doing daily spontaneous breathing trials, automatic reductions in support are not going to facilitate that as long as you're doing those. Most of these algorithms, these automated algorithms, take a pressure-targeted mode, be it pressure support or pressure assist control, and put some kind of a feedback mechanism in there. The simplest one is pressure-regulated volume control or volume support, and that simply uses a tidal volume target. And as long as the patient maintains a certain tidal volume, the pressure will gradually be reduced. Is that helpful? I'm not sure. I'm not sure. And like I said, I'm suspicious that this may be unnecessary stress on the patients. More sophisticated versions exist. I don't have time to go into them. One of the most commonly quoted is a brand name called SmartCare. Again, it's an algorithm that reduces the level of pressure during pressure support or pressure assist control. It uses not only tidal volume, but it uses minute ventilation, end tidal CO2 as well. And adaptive support ventilation, which uses the calculated work of breathing to set a frequency tidal volume ratio and adjust pressure accordingly. These are all feedback mechanisms that have been looked at during the ventilator discontinuation process. So volume support, adaptive support ventilation, again, adjusts pressure to targeted tidal volumes. In theory, it may help by dropping the pressure support. In practice, if you set the tidal volume too high, they're never going to come off the ventilator. If you set it too low, you may overload them. And the problem is if the patient has a transient episode of anxiety or pain or discomfort, they may take a couple of deep breaths and the ventilator thinks that things are getting better and actually withdraws support. You have to know what you're doing if you're going to use these automated supports. SmartCare was looked at very carefully in one trial that was published about 10 years ago now in the Blue Journal, and there was a lot of excitement because, as you can see on this graph, the SmartCare people, the dark line, came off the ventilator quicker. And a lot of people said, oh my goodness, maybe there is something to this. This study, however, I think is a very good case study in pitfalls in randomized controlled trials. What's the pitfall here? The pitfall is the control group. The control group did not get spontaneous breathing trials. So right off the bat, if you have a crummy control group, your intervention or your innovation may look awfully good. When the study was repeated, lo and behold, the difference went away. At the moment, SmartCare is as good as a good clinician doing daily spontaneous breathing trials, or at least it appears to be. It does require spontaneous breathing trials, and it warns the clinician to do a spontaneous breathing trial. But at the moment, it seems like a lot of complexity and ventilator sophistication to do what a good respiratory therapist can do with a protocolized spontaneous breathing trial approach. So is there a role for automatic pressure reduction? And as I say, in most patients in an ICU, I'm not sure this has any applicability. Having said that, I do think there are two scenarios where this may be helpful. And it's actually using this algorithm not as a therapeutic maneuver, increasing loads to exercise muscles, but instead using these modes as a diagnostic tool and a monitoring tool. For example, a drug overdose or a patient waking up from anesthesia, these algorithms could be very useful in recognizing when patients are starting to breathe on their own, which could be only a matter of hours, and alerting the clinician that things are ready to go. That has appeal. And the flip side of that is in these long-term players. You've done spontaneous breathing trials up the yin-yang. They're not passing them. Maybe it's time to let the lungs do whatever recovery they can before we go on to try spontaneous breathing trials again. And here's another location where these automated systems might be useful. Because as patients get better, indeed, in theory I should say, these modes should signal that with gradual reductions in support over days or even weeks. warning you, or not warning you, but alerting you that maybe the patient is getting better and maybe you can restart spontaneous breathing trials. And there are a number of long-term facilities around the country that have protocols in place that say, look, this patient's been unable to come off the ventilator after multiple spontaneous breathing trials. We've got to demonstrate a reduction in support because of improvement in lung function before we're going to try a spontaneous breathing trial again. And there are various algorithms out there, reduce the ventilatory support by 30%, 40%, 50% before restarting spontaneous breathing trials. And these automated systems may actually help us in that regard. So a couple of places where maybe an automated system could play a role. But again, I'll come back to the routine ICU patients, those 96 or 94% who come off in 3 spontaneous breathing trials or less. I'm not convinced that these algorithms offer much benefit. Okay, we've covered a lot. Let me sort of summarize and conclude here. First off, ventilator dependence is not only disease-related, but it's also iatrogenic. Good evidence supports daily screening and spontaneous breathing trials, and success is enhanced if you have a sedation protocol that minimizes sedation. If you pass your spontaneous breathing trial, you need a second assessment before you yank the tube. Failed spontaneous breathing trials, at least in standard ICUs, require another 24 hours of stable support while you address the problems of acute respiratory failure, and then come back and do it again. Again, I'll repeat one more time, gradual reductions in support in between those spontaneous breathing trials has really not been shown to do much of anything other than waste your time. NIV is growing in popularity to both facilitate or to both help prevent intubations in the COPD population, but also to facilitate yanking the tube, getting the patient off the ventilator, also primarily in COPD. And finally, automated strategies may have a role in the rapidly recovering patient, the post-op, the overdose, and it may be useful in prolonged mechanical ventilation where improvement in lung function may take a long, long time. Again, I'm not so sure this is a therapy as much as it is a marker of disease. I think the guidelines that were published in 2001 are still valid today, and I think every respiratory therapist ought to have access to them. CHEST 2001, December, Respiratory Care, January 2002. And they ought to be in everybody's respiratory care literature folder. The new guideline updates are useful, but I don't think have added or changed substantially what was evidence-based and guideline-driven back in 2001. So with that, I'll close. Thank you all for your attention and appreciate you being with us today.